What is the underlying pathophysiological mechanism of psoriasis and how does it influence treatment options? Answer. Psoriasis is a chronic autoimmune condition characterized by hyperproliferation of keratinocytes and an inflammatory infiltrate primarily consisting of T helper 1 and 17 cells. The pathophysiology involves a dysregulated immune response leading to increased production of pro-inflammatory cytokines such as tumor necrosis factor alpha, TNF, interleukin IL-1 and IL-17. These cytokines contribute to the inflammation and scaling seen in psoriatic lesions. The influence on treatment options is significant. For instance, biologic therapies targeting TNF or IL-17 pathways, e.g., adalimumab, secukinumab, have emerged as effective treatments due to their ability to modulate the underlying immune response. Additionally, topical therapies, e.g., corticosteroids, vitamin D analogs, aim to reduce inflammation and keratinocyte proliferation, while systemic therapies, e.g., methotrexate, acitretin, provide broader immunosuppression. Relevant guidelines. National Psoriasis Foundation recommends individualized treatment based on disease severity, patient preference, and comorbid conditions. Explain the different types of skin biopsy techniques and their indications in the diagnosis of skin lesions. Answer. Skin biopsy is crucial for the diagnosis of various dermatological conditions. The three primary types of biopsy techniques include punch biopsy, indication, useful for obtaining a full-thickness skin sample, indicated for inflammatory skin disorders, e.g., psoriasis, eczema, and certain tumors. Technique. A circular blade is used to remove a cylindrical section of skin, including the epidermis and part of the dermis. Shave biopsy, indication, ideal for superficial lesions such as warts or seborrheic keratosis. Technique. The lesion is shaved off at the level of the surrounding skin, preserving deeper structures. Excisional biopsy, indication, recommended for suspected malignant lesions, e.g., melanoma, where complete removal is necessary for both diagnosis and treatment. Technique. A scalpel is used to excise the lesion along with a margin of surrounding tissue. Each technique has its specific applications based on the characteristics of the lesion and the suspected diagnosis. Relevant guidelines. The American Academy of Dermatology emphasizes the importance of selecting the appropriate biopsy technique based on clinical suspicion and the nature of the lesion. Mr. Anderson, a 45-year-old male, presents with a painful erythematous lesion on his left forearm after he recently went hiking. The lesion is filled with pus and has a well-defined border. Considering this presentation, what are the key differential diagnoses and what initial management steps should be taken? Answer. Key differential diagnoses include bacterial folliculitis, inflammation of hair follicles due to bacterial infection often presenting as pustules, abscess, a localized collection of pus that often requires drainage, typically caused by Staphylococcus aureus, cellulitis, an infection of the skin and subcutaneous tissue presenting with redness and swelling, but typically does not form, a localized collection of pus initially. Initial management steps, incision and drainage, i.e., if an abscess is confirmed, it should be drained to relieve pain and facilitate healing. Culture and sensitivity. Obtain a sample of the pus for microbial culture to identify the causative organism. Antibiotic therapy. Initiate empirical antibiotics, such as cefalexin or clindamycin, pending culture results. Discuss the classification of topical corticosteroids and their clinical applications, including potential side effects. Answer. Topical corticosteroids are classified into 4 categories based on their potency. Class I, super high potency. Examples: clobtasol propionate. Clinical applications used for severe inflammatory conditions such as plaque psoriasis and severe eczema. Side effects: risk of skin atrophy and telangiectasia with prolonged use. Class II, high potency. Examples: fluocinonide, betamethasone dipropionate. Clinical applications: effective for moderate to severe dermatitis and localized psoriasis. Side effects: similar to Class I but slightly low risk. Class Rome Thuvi, medium to low potency. Examples: triamcinolone acetonide, Classome throhydrocortisone coromina. Clinical applications: suitable for mild inflammatory conditions and for sensitive areas like the face and intertriginous areas. Side effects: generally low risk, but prolonged use can still lead to local side effects. Key considerations: duration of use should be limited and patients should be monitored for potential side effects, especially in high-potency agents. The use of occlusive dressings can enhance absorption and efficacy but increases the risk of side effects. Relevant guidelines. The American Academy of Dermatology recommends a step-down approach, tapering the potency as the condition improves. What factors should be considered when selecting an antibiotic for a patient with a suspected bacterial skin infection? Answer: when selecting an antibiotic for a bacterial skin infection, several factors must be considered. Causative organism. Identify the likely pathogens based on the clinical presentation. Common organisms include Staphylococcus aureus and Streptococcus pyogenes. If the patient has a history of MRSA, methicillin-resistant Staphylococcus aureus, coverage should be considered. Site of infection. Consider the site and severity of the infection. For deeper or systemic infections, parenteral antibiotics may be warranted. Patient factors. Assess renal and hepatic function, potential drug allergies, and patient comorbidities, which may affect antibiotic choice. Resistance patterns. Be aware of local antibiotic resistance patterns to select appropriate empirical therapy, route of administration. Determine whether oral or intravenous administration is necessary based on severity and patient compliance. What are the key clinical features that differentiate basal cell carcinoma (BCC) from squamous cell carcinoma (SCA)? Answer: the differentiation between basal cell carcinoma (BCC) and squamous cell carcinoma (SCC) relies on distinct clinical features. Basal cell carcinoma (BCC) appearance often presents as a pearly or waxy nodular lesion with telangiectasia, may also appear as a flat, scaly area that is flesh-colored or brown. Location: commonly found on sun-exposed areas such as the face and neck. Growth pattern: slow growing and rarely metastasizes. A local invasion is more common. Squamous cell carcinoma (SCC) appearance typically presents as a firm, red nodule or a scaly, crusted lesion and may ulcerate and bleed. Location: can occur on sun-exposed areas as well, but also on non-exposed skin and may arise from pre-existing lesions like actinic keratosis. Growth pattern: more aggressive than BCC and has the potential to metastasize, particularly in high-risk areas, e.g. lips. Key considerations: a thorough history and physical examination are essential for accurate diagnosis, as well as potential biopsy for definitive diagnosis. Relevant guidelines. The American Academy of Dermatology provides recommendations for the management and treatment of non-melanoma skin cancers, emphasizing early detection and intervention. What are the mechanisms of action of topical calcineurin inhibitors, TCIS, and how do they differ from traditional corticosteroids? Answer: topical calcineurin inhibitors, TCIS, such as tacrolimus and pimecrolimus, exert their effects through the following mechanisms. Mechanism of action: TCIS inhibit calcineurin, a protein phosphatase that plays a critical role in T-cell activation. By blocking this pathway, TCIS reduce the release of pro-inflammatory cytokines, thereby decreasing inflammation. Clinical application: they are particularly effective in treating atopic dermatitis and other inflammatory skin conditions where corticosteroids may pose a risk of side effects, especially in sensitive areas. Comparison with corticosteroids. Efficacy: both TCIS and corticosteroids are effective in managing inflammation, but TCIS do not carry the risk of skin atrophy associated with prolonged corticosteroid use. Side effects: TCIS may cause burning or stinging upon application, but do not lead to long-term skin changes. Corticosteroids can lead to skin thinning, telangiectasia, and rebound flares upon withdrawal. Discuss the multifaceted approach to managing moderate to severe acne vulgaris, including pharmacological and non-pharmacological strategies. Answer: management of moderate to severe acne vulgaris requires a comprehensive approach that combines pharmacological and non-pharmacological strategies. Pharmacological strategies: topical retinoids promote cell turnover and prevent comedone formation, e.g. tretinoin, adapalene. Antibiotics: topical clindamycin, benzoyl peroxide, or systemic doxycycline, minocycline to reduce bacteria and inflammation. Hormonal therapies: oral contraceptives can be effective in females by regulating androgen levels. Isotretinoin, for severe cases unresponsive to other treatments. It works by reducing sebum production, preventing comedone formation, and has anti-inflammatory effects. Non-pharmacological strategies: skincare regimen, gentle cleansing with non-comedogenic products, avoiding abrasive scrubs. Dietary modifications: emerging evidence suggests that high glycemic index foods and dairy may exacerbate acne, so dietary adjustments can be beneficial. What are the key principles of burn management, and how do you determine the appropriate treatment based on burn classification? Answer: burn management is guided by the classification of burns, which includes first degree, superficial, second degree, partial thickness, and third degree, full thickness burns. Key principles of management include: first degree burns. Characteristics: affect only the epidermis, presenting as red and dry with no blisters. Management: Symptomatic treatment with cool compressors, aloe vera, and analgesics usually heals within days without scarring. Second-degree burns characteristics involve the epidermis and part of the dermis with blisters and swelling. Management. Wound care includes cleaning, applying antibiotic ointments, and covering with sterile dressings. If extensive, consider referral to a burn center. Third-degree burns characteristics affect all skin layers, often appearing white, leathery, or charred. Management requires surgical intervention, e.g., debridement, grafting, and comprehensive wound care. Hospitalization is typically necessary. Determining treatment. Assess the depth, extent, percentage of body surface area affected, and location of the burn. Use the rule of nines or Lund-Browder chart for estimating burn size. Relevant guidelines. The American Burn Association provides extensive guidelines on the management of burn injuries, emphasizing the importance of specialized care for severe burns. Explain the pathophysiology of urticaria and angioedema and describe the first-line management strategies for acute episodes. Answer. Urticaria, hives, and angioedema, swelling beneath the skin, result from the release of histamine and other mediators from mast cells in response to various triggers, including allergens, medications, or physical stimuli. The underlying mechanism involves mast cell activation. Allergens cross-link with antibodies on mast cells, leading to degranulation and the release of histamine, which causes vasodilation and increased vascular permeability. Symptoms. Urticaria presents as raised, itchy wheals, while angioedema typically affects deeper layers of the skin, especially around the eyes and lips. Management strategies for acute episodes. Antihistamines. First-line treatment includes second-generation antihistamines, e.g., cetirizine, loratadine, to relieve itching and hives. Corticosteroids. Short courses of systemic corticosteroids may be considered for severe or persistent cases. Avoidance of triggers. Identifying and avoiding known triggers can help prevent recurrence. What are the primary physiological effects of glucagon, and how does it counteract insulin's effects in the context of diabetes management? Answer. Glucagon is a peptide hormone produced by the alpha cells of the pancreas. Its primary function is to increase blood glucose levels, especially during fasting or between meals. Glucagon stimulates glycogenolysis, the breakdown of glycogen to glucose in the liver, and promotes gluconeogenesis, the synthesis of glucose from non-carbohydrate sources. In contrast, insulin, produced by the beta cells of the pancreas, decreases blood glucose levels by facilitating cellular uptake of glucose, promoting glycogenesis, conversion of glucose to glycogen, and inhibiting gluconeogenesis. In diabetes, particularly type 1 diabetes where insulin production is inadequate, glucagon's action becomes unchecked, leading to hypoglycemia. Understanding this counter-regulatory mechanism is crucial for effective diabetes management, as it highlights the importance of balancing insulin and glucagon actions in treatment plans. Explain the pathophysiology of Cushing's syndrome and its effects on the body. What diagnostic tests would be appropriate to confirm this diagnosis? Answer. Cushing's syndrome results from prolonged exposure to elevated cortisol levels, which can occur due to various causes, including adrenal tumors, pituitary adenomas, Cushing's disease, or ectopic ACTH production. The pathophysiology involves an imbalance in the hypothalamic-pituitary HEA axis, leading to excessive adrenal hormone production. The clinical manifestations include weight gain, central obesity, purple striae, easy bruising, hypertension, and metabolic changes such as insulin resistance. Additionally, patients may exhibit symptoms like mood changes, hirsutism, and menstrual irregularities. To confirm the diagnosis of Cushing's syndrome, several diagnostic tests can be utilized. 24-hour urine-free cortisol test measures the amount of cortisol excreted in urine over a day. Low-dose dexamethasone suppression test assesses how cortisol levels respond to dexamethasone in Cushing's. Cortisol levels remain elevated. Salivary cortisol test. Evening salivary cortisol levels are typically elevated in Cushing's syndrome. Mr. Thompson is a 58-year-old male who presents with fatigue, weight gain, and frequent urination. Upon evaluation, his blood glucose levels are significantly elevated and his HbAC is 8.5%. He has a family history of diabetes. Considering his symptoms and lab results, what management strategies should be recommended for Mr. Thompson, including lifestyle modifications and pharmacologic options? Answer. Given Mr. Thompson's presentation of fatigue, weight gain, frequent urination, and elevated H-back, he is likely diagnosed with type 2 diabetes mellitus. The management strategies for Mr. Thompson should encompass lifestyle modifications and pharmacological interventions. Lifestyle modifications. Diet. Encourage a balanced diet focused on whole foods, reducing simple sugars and refined carbohydrates to improve glycemic control. Physical activity. Recommend at least 150 minutes of moderate intensity aerobic exercise per week to promote weight loss and enhance insulin sensitivity. Weight management. A goal of losing 5.10% of body weight can significantly improve glycemic control. Pharmacologic options. Metformin. This first-line oral hypoglycemic agent improves insulin sensitivity and decreases hepatic glucose production. ADLT inhibitors e.g. empagliflozin can help with weight loss and cardiovascular protection while also lowering blood glucose levels by promoting glucose excretion through the urine. GLP-1 receptor agonists e.g. liraglutide, useful for patients who need further glycemic control as they promote satiety and weight loss. Regular follow-up and monitoring of blood glucose levels and H-back are crucial to adjust treatment plans as needed. Discuss the mechanism of action of levothyroxine and its role in the management of hypothyroidism. How does the dosing of this medication differ in various patient populations? Answer. Levothyroxine is a synthetic form of thyroxine used in the treatment of hypothyroidism. It acts by restoring the physiological levels of thyroid hormones, thereby increasing metabolic rate and affecting virtually all body systems, including growth, development, and energy metabolism. Mechanism of action. Levothyroxine is converted to its active form, triiodothyronine, in peripheral tissues. It binds to thyroid hormone receptors in the nucleus of cells, regulating the expression of genes involved in metabolism. Dosing considerations. Dosing of levothyroxine may differ based on age, weight, pregnancy status, and comorbidities. In adults, the usual starting dose is 1 sachet a day, with adjustments made based on TSH levels. In elderly patients, particularly those with cardiovascular disease, a lower starting dose e.g. 12.5 to 25 mg/day is often recommended to mitigate the risk of adverse cardiovascular events. What are the potential complications of untreated hypothyroidism and what management strategies are available to mitigate these risks? Answer. Untreated hypothyroidism can lead to several complications, including thyroid storm, a life-threatening exacerbation of hypothyroidism characterized by fever, tachycardia, and altered mental status; osteoporosis, increased bone resorption due to elevated thyroid hormone levels can lead to decreased bone density and higher fracture risk; cardiovascular issues. Patients may develop atrial fibrillation, increased cardiac output, and potential heart failure due to prolonged elevated heart rates. Management strategies. Pharmacologic treatment. Antithyroid medications e.g. metamizole or propylthiouracil to reduce thyroid hormone production. Beta blockers e.g. propranolol for symptom control, particularly for tachycardia and anxiety. Radioactive iodine therapy destroys overactive thyroid cells and is a common long-term solution. Surgery. In cases of large goiters or when other treatments are not effective, thyroidectomy may be indicated. Close monitoring of thyroid function tests is essential throughout treatment to adjust therapies as needed and prevent complications. Explain the role of ACTH stimulation tests in diagnosing adrenal insufficiency and the expected outcomes in primary versus secondary adrenal insufficiency. Answer. The ACTH stimulation test evaluates the adrenal gland's response to adrenocorticotropic hormone X. In this test, synthetic ACTH is administered and plasma cortisol levels are measured at baseline and after stimulation. Expected outcomes. In primary adrenal insufficiency e.g. Addison's disease, the adrenal glands are damaged and cannot produce cortisol adequately. Following ACTH administration, cortisol levels will be low or fail to rise significantly. In secondary adrenal insufficiency, often due to pituitary dysfunction, the adrenal glands may still be functional, but cortisol production is insufficient due to low ACTH levels. Here, cortisol levels may increase, but not to the extent seen in healthy individuals. This test is crucial for differentiating between primary and secondary adrenal insufficiency, allowing for targeted treatment approaches. MS Rivera, a 45-year-old female, presents with fatigue, weight gain, and joint pain. Laboratory tests reveal elevated TSH and low free T levels, indicating hypothyroidism. After initiating levothyroxine therapy, she reports that her symptoms have improved but still experiences intermittent fatigue. What considerations should be made in her ongoing management, including potential dosage adjustments and monitoring strategies? Answer: in managing MS, reverse hypothyroidism, the following considerations should be made. Dosage adjustments. The standard starting dose of levothyroxine may need to be adjusted based on her TSH levels. If her TSH remains elevated after 6 to 8 weeks of therapy, an increase in levothyroxine dosage should be considered. Regular monitoring is crucial. If the TSH level should ideally be maintained in the lower half of the reference range. Monitoring strategies. TSH and free T levels should be measured every 6-8 weeks after starting treatment or adjusting the dose, then every 1-2 months once stable. If MS Rivera is experiencing intermittent fatigue despite normalized thyroid hormone levels, it may be essential to evaluate other potential causes, such as anemia, depression, or other underlying health conditions. Patient education. Educate MS Rivera on the importance of medication adherence and the timing of levothyroxine administration on an empty stomach, usually in the morning. Discuss potential interactions with certain foods like calcium or iron supplements that may affect absorption. Overall, a comprehensive approach including regular monitoring, patient education, and timely adjustments to therapy will be vital in ensuring MS Rivera's symptoms are managed effectively. Describe the mechanisms of action of EDLT inhibitors and their role in the management of diabetes and associated cardiovascular benefits. Answer: EDLT inhibitors, sodium glucose cotransporter 2 inhibitors, are a class of medications used to manage type 2 diabetes. Their primary mechanism of action involves the inhibition of EDLT protein in the proximal tubule of the kidney, which is responsible for glucose reabsorption from the urine back into the bloodstream. Mechanism of action. By inhibiting EDLT, these medications increase urinary glucose excretion, thereby lowering blood glucose levels. This action leads to osmotic diuresis, promoting weight loss and reducing blood pressure, both beneficial effects in patients with type 2 diabetes. Cardiovascular benefits. Recent studies, such as the IMPAREGO-UTCOME trial, have demonstrated that EDLT inhibitors are associated with reduced cardiovascular mortality and heart failure hospitalizations in diabetic patients, attributed to their diuretic effects and improvement in cardiac hemodynamics. These agents also show promise in improving renal outcomes, which is crucial given the increased risk of nephropathy in diabetic patients. What are the primary considerations in the management of patients with pheochromocytoma, and how does this condition impact perioperative care? Answer: pheochromocytoma is a rare tumor of the adrenal medulla that secretes catecholamines, epinephrine, and norepinephrine, leading to episodic hypertension and various symptoms such as palpitations, headaches, and sweating. Management considerations. Preoperative management. Patients must be appropriately prepared before surgical resection, including the initiation of alpha-adrenergic blockade, e.g. phenoxybenzamine, to control hypertension and prevent intraoperative hypertensive crises. Beta blockers should be used cautiously and only after adequate alpha blockade to prevent exacerbation of hypertension. Surgical approach. Surgical removal of the tumor is the definitive treatment, and care must be taken to monitor and manage hemodynamics during the procedure. Intraoperative monitoring of blood pressure and heart rate is crucial, as rapid fluctuations can occur due to catecholamine release. Postoperative care. Patients require close monitoring in the postoperative period for hypotension and potential adrenal insufficiency due to disruption of normal adrenal function. Follow-up care should include monitoring of plasma-free metaphrines to detect any residual or recurrent disease. What is the significance of thyroid function tests in diagnosing hypothyroidism, and how should these tests be interpreted in conjunction with clinical findings? Answer: thyroid function tests are essential in diagnosing hypothyroidism. The primary tests include serum levels of TSH, thyroid-stimulating hormone, and free thyroxine. Interpretation. TSH levels. In hypothyroidism, TSH levels are typically suppressed due to negative feedback from elevated thyroid hormones. Low TSH is a critical indicator of hypothyroidism. Free T levels. Elevated free T levels confirm the diagnosis, while free T levels may also be measured, particularly in cases of toxicosis. Clinical correlation. Symptoms such as weight loss, palpitations, tremors, and heat intolerance, when combined with laboratory findings, solidify the diagnosis of hypothyroidism. It is also crucial to consider potential causes such as Graves' disease, toxic adenoma, or thyroiditis, necessitating further testing, e. G. Radioactive iodine uptake, thyroid antibodies, to determine the underlying etiology. A 67-year-old female patient presents to the emergency department with sudden onset weakness of the right arm and slurred speech. What immediate management steps should be taken for this patient? Discuss the relevant guidelines for stroke treatment. Answer: the immediate management of an acute stroke includes the following steps. Assessment and diagnosis. Conduct a rapid assessment using the NIH stroke scale to evaluate the severity of the stroke. A non-contrast CT scan should be performed promptly to differentiate between ischemic and hemorrhagic stroke. Thrombolytic therapy. If the CT confirms an ischemic stroke and the patient meets the criteria e.g. symptom onset within 3 to 4.5 hours, no contraindications, intravenous tissue plasminogen activator (TPA) should be administered. The American Heart Association American Stroke Association HASA guidelines recommend administering TPA as soon as possible. Monitoring. Continuous monitoring of the patient's neurological status and vital signs is essential for early detection of potential complications, such as hemorrhage. Multidisciplinary team approach. Engage neurologists, nursing staff, and rehabilitation specialists early in the process to optimize recovery. These guidelines are outlined in the HASA's Guidelines for the Early Management of Patients with Acute Ischemic Stroke, 2019. Explain the pharmacological management options for a patient diagnosed with Parkinson's disease. What are the mechanisms of action of the primary medications used in this condition? Answer: the pharmacological management of Parkinson's disease primarily includes levodopa-carbidopa. This combination is the most effective treatment. Levodopa is converted to dopamine in the brain, compensating for the reduced levels due to dopaminergic neuron loss. Carbidopa prevents levodopa from converting to dopamine outside the brain, reducing side effects like nausea. Dopamine agonists e.g. pramipexole, rapinol. These medications stimulate dopamine receptors directly. They are often used as adjuncts to levodopa or in younger patients to delay the initiation of levodopa therapy. MAO-B inhibitors e.g. selagelene, rasagiline. These drugs inhibit the monoamine oxidase B enzyme, which breaks down dopamine, thereby increasing its availability in the brain. COMT inhibitors e.g. entacapone. These medications prolong the effect of levodopa by inhibiting its metabolism, allowing for a more stable dopamine level. Amantadine, initially an antiviral. This drug has dopaminergic effects and can help reduce dyskinesias in patients on long-term levodopa therapy. Treatment should be individualized based on the patient's symptoms, age, and potential side effects. Regular follow-up is crucial for adjusting medication dosages as the disease progresses. A 32-year-old male presents to the clinic with recurrent seizures. What diagnostic workup is necessary to evaluate his condition, and what initial treatment options should be considered? Answer: the diagnostic workup for a patient with recurrent seizures includes detailed history and physical examination, understanding the type of seizures e.g. focal versus generalized and triggers, electroencephalogram e.g. This is the primary diagnostic tool for identifying seizure activity and potential focal origins. Neuroimaging, MRI of the brain, is essential to rule out structural abnormalities such as tumors or malformations. Laboratory tests, basic metabolic panel, complete blood count, and toxicology screen should be performed to exclude metabolic causes or drug-induced seizures. Initial treatment options include antiepileptic medications, EEDs. The choice of AED depends on the seizure type. Common options include levetiracetam, broad spectrum and well tolerated. Valpro, effective for generalized seizures. Lamotrigine, useful for both focal and generalized seizures. A 45-year-old female patient presents with episodes of visual disturbances and unilateral weakness. What diagnostic criteria should be utilized to confirm a diagnosis of multiple sclerosis MS? Answer: the diagnosis of multiple sclerosis is based on the McDonald criteria, which include evidence of dissemination in space (DIS). This can be established through MRI findings showing lesions in 2 or more areas of the central nervous system (CNS), such as paraventricular, cortical, and infratentorial regions. Evidence of dissemination in time (DIC). This indicates that lesions or clinical events occurred at different times, which can be supported by a new lesion appearing on follow-up MRI or clinical relapses separated by time. Exclusion of other conditions. It is crucial to rule out other neurological disorders that could explain the symptoms and MRI findings. The use of cerebrospinal fluid (CSF) analysis to detect oligoconal bands may also support the diagnosis. However, it is not mandatory for confirming MS. Mr. Smith, a 58-year-old diabetic patient, reports increasing numbness and tingling in his feet. He is concerned about developing diabetic neuropathy. What steps should Mr. Smith take to manage his condition, and what are the evidence-based guidelines for diabetic neuropathy treatment? Answer: Mr. Smith should consider the following steps to manage his condition. Glycemic control. Maintaining optimal blood glucose levels is crucial in preventing the progression of diabetic neuropathy. The American Diabetes Association (ADA) recommends a target HbAC level of less than 7%. Foot care. Regular foot examinations and education on proper foot hygiene are essential to prevent complications. Pharmacologic treatment. If Mr. Smith develops painful diabetic neuropathy, he may consider the following medications: gabapentin or pregabalin. These are first-line treatments that modulate calcium channels and reduce neuropathic pain. Duloxetine. This is a serotonin norepinephrine reuptake inhibitor (SNRI) that has shown efficacy in neuropathic pain management. Lifestyle modifications. Mr. Smith should also be encouraged to engage in regular physical activity, maintain a healthy diet, and avoid alcohol, as these can help improve overall nerve health. A 72-year-old male presents with a sudden severe headache, confusion, and loss of consciousness. What diagnostic tests should be performed to evaluate for intracranial hemorrhage, and what are the key indicators of this condition? Answer: in this clinical scenario, the following diagnostic tests should be performed. Non-contrast CT scan of the head. This is the first-line imaging modality for detecting acute intracranial hemorrhage. Key indicators include hyperdense areas on CT indicating the presence of blood, location of the hemorrhage, subarachnoid, subdural, or epidural, neurological assessment. Regular neurological examinations to monitor changes in consciousness, pupil response, and motor function are essential. Lumbar puncture. This may be considered if the CT is inconclusive and there is a suspicion of subarachnoid hemorrhage based on clinical symptoms, provided there are no contraindications such as elevated intracranial pressure. Management will depend on the type and severity of the hemorrhage, with potential surgical intervention in cases of significant mass effect or ongoing bleeding. Discuss the treatment options for Bell's palsy and the underlying pathophysiology associated with this condition. Answer: Bell's palsy is characterized by the sudden onset of unilateral facial paralysis due to inflammation of the facial nerve. Cranial nervome and treatment options include corticosteroids. Prednisone is the primary treatment to reduce inflammation and swelling of the facial nerve. The efficacy is highest when started within 72 hours of symptom onset. Antiviral medications. While their role is still debated, antivirals like acyclovir may be considered, especially if there is a suspected viral etiology, such as herpes simplex virus. Physical therapy. Early facial exercises may help maintain muscle tone and prevent contractures during recovery. Supportive care. Analgesics and artificial tears may be recommended to manage discomfort and protect the eye on the affected side. The prognosis for Bell's palsy is generally favorable, with most patients experiencing significant recovery within 3 to 6 months. A 30-year-old female with a history of chronic migraines reports that her current abortive medication, sumatriptan, is becoming less effective. What should be considered in her management plan, and what are the guidelines for transitioning to a new treatment regimen? Answer: for patients experiencing decreased efficacy of their abortive migraine medications, the following management strategies should be considered. Medication overuse assessment. Evaluate whether the patient is overusing acute medications, which can lead to rebound headaches. Alternative abortive medications. Transition to other triptans, e.g. rizatriptan or elatriptan, or consider non-triptan options like NSAIDs, e.g. ibuprofen or naproxen or ergotamine derivatives. Preventive therapy. Initiating or adjusting preventive treatment may be beneficial. Options include beta blockers, e.g. propranolol, effective for reducing migraine frequency. Antidepressants, e.g. amitriptyline, may help in cases with comorbid depression or anxiety. Antiepileptic drugs, e.g. topiramate, effective for migraine prophylaxis. Lifestyle modifications encourage dietary changes, stress management techniques, and regular exercise, as these can significantly impact migraine frequency and severity. A 42-year-old office worker presents with numbness and tingling in the first 3 fingers of her right hand, particularly at night. What diagnostic tests should be considered to confirm carpal tunnel syndrome, and what conservative management strategies can be implemented? Answer: to confirm a diagnosis of carpal tunnel syndrome, CTS, the following diagnostic tests may be performed. Phelan's test. The patient flexes her wrists for 60 seconds to see if symptoms are reproduced. Tinel's sign. Tapping over the median nerve at the wrist may elicit symptoms indicating nerve irritation. Nerve conduction studies, NCS. This is the most definitive test and measures the speed of electrical impulses through the median nerve. Conservative management strategies include Wrist splinting. Using a wrist splint at night can help keep the wrist in a neutral position, reducing pressure on the median nerve. Activity modification. The patient should be advised to take regular breaks from repetitive hand movements, and ergonomic adjustments to her workstation may be beneficial. Corticosteroid injections. In cases of persistent symptoms, corticosteroid injections into the carpal tunnel may reduce inflammation and alleviate symptoms. Physical therapy. Exercises to strengthen the wrist and hand may also be recommended. Discuss the pharmacotherapy options available for a patient diagnosed with Alzheimer's disease. What are the mechanisms of action and indications for these medications? Answer. The pharmacotherapy options for Alzheimer's disease primarily include cholinesterase inhibitors, G-donepezil, rivastigmine, galantamine. These medications inhibit the breakdown of acetylcholine, thereby increasing its levels in the brain. They are indicated for mild to moderate Alzheimer's disease and may help improve cognitive symptoms. NMDA receptor antagonists, G-memantine. Memantine works by regulating glutamate activity, which is involved in learning and memory. It is indicated for moderate to severe Alzheimer's disease and may be used alone or in conjunction with cholinesterase inhibitors. Combination therapy. In some cases, a combination of a cholinesterase inhibitor and memantine may be considered to provide a more comprehensive approach to symptom management. Lifestyle modifications. Alongside pharmacotherapy, non-pharmacological interventions such as cognitive stimulation therapy and caregiver support are crucial for comprehensive care.